Good evening and welcome to Colorado. How many of you have been to a CFHA conference in this state before? All right, mainly this side of the room, interesting. What's going on over here, guys? Spread out. Okay, and how many of you, is this your first CFHA conference? Okay, let's keep playing this game. This is good. I'm going to curveball here. How many of you think that policy is a part of your job? Ooh, that was a fast, look at this. Okay, you guys take a look around. Keep your hands up, right, do them again. I'm going to say that's like 83% of the room. A couple of you in the back didn't raise your hands. We'll get to you later. But this is a unique moment in time. And let me take you back in history for a few minutes. 1952, Richard Nixon, the first president to declare a crisis in healthcare. Did you know that? And did you know that every president since 1952 has declared healthcare as in crisis? 1963, JFK signed one of the most consequential laws that deinstitutionalized mental health, put mental health into community. 1965, we created this thing called CMS, Medicare, Medicaid. You may have heard of that. And I could go on and on and on. But I want to take you to 2 nights ago. There was this debate. You guys may know that something's happening in our country right now. We're deciding the future of our nation, maybe the future of the world, who knows, we'll see. But there was a moment in this debate where opioids came up. And it was stunning because in 3.5 hours of listening to people talk, you're like, oh, they're finally getting to my topic. And opioids was discussed for maybe 93 seconds. Go back and watch. The topic of mental health and addiction is one of the most pressing topics we can be discussing in health policy, period. Because where we are, folks, is not in a good place. My mentor, one of my mentors, Dr. Larry Green, defined policy as movement in a direction for a reason. The direction that we're heading in policy is the wrong direction if we're not helping people get better. We lost more lives on record 2 years ago to drug, alcohol, and suicide than we've ever lost before. This is our time to do something meaningful for policy. Tonight's panel is going to take us there. It's going to describe where we currently are, the near horizon, what's happening in health policy in our states, in our communities, in the country. But then it's also going to take us to the future. What is the far horizon for healthcare? Where do we need to go together to advance policy that's more comprehensive, meaningful for the lives of so many people out there that are looking to you, that are looking to me, that are looking to organizations like CFHA to help lead? So with that, I want to introduce our panel, and I'm going to start by John Daley, who's moderating. If you're in Colorado, you know you could just close your eyes and listen to John because you hear him every day on the radio. He is the health reporter for Colorado Public Radio, CPR.org, CPAR.org. That's hard to do, John. Whew, they're doing Fund Drive right now, and so you hear that all the time. I was telling John. But this panel is really special to me because not only do we have some of the most amazing leaders, we have amazing different perspectives. You're going to hear a lot about what is possible, but I hope what you leave with is inspiration because policy is all our responsibilities. So I'll turn it over to John.
Hi there. Got our panel coming up. Welcome to Colorado for those of you who haven't been here before, and for those of you who live here, I'm glad to see you as well. So here's the plan. We're going to try to keep this quick and lively, and we're going to be talking about health policy, mental health policy, and we want to reflect on what's happening in the near future, the near horizon, and also the far horizon. And with Ben's help, we've got a kind of fun way to do this, which is we've got everybody introducing themselves and introducing a song that helps kind of encapsulate what the messages that they're going to try to impart to you. So let me start with Representative Leslie Herod from Denver. And Leslie, tell us about your song.
Wow. Good evening, everyone. I am State Representative Leslie Herod. I represent House District 8 in Central and Northeast Denver. I am proud to be the first African-American LGBT person to hold elected office in Colorado. Thank you. And I picked a song that you guys might all recognize. Are we playing the song or do I just talk about it?
I think you're going to push the button there.
Oh, look at this.
Let's see. There's the green.
Oh, green, there you go. All right, near horizon. Nothing's happening.
All right.
I'm not gonna sing, you guys
There you
will
go.
not.
There's a picture. Oh, this
You
is
guys
your
will
image?
not like it. So I'm really excited because this past year, Denver was able to pass a ballot measure called Caring for Denver. Has anyone in the audience heard of Caring for Denver? A couple of people, that's okay. I know there's not a lot of Denverites here. Caring for Denver was a unique ballot measure. So yes, I'm a state legislator, but I also live in Denver. And as the chair of the Finance Committee and the vice chair of the Judiciary Committee, I see what happens firsthand when we don't adequately fund mental health and addiction services right here in Denver. Quite frankly, it's straining our state budgets at all levels. So because Colorado has a very interesting fiscal situation,
Indeed.
I realized quickly that talking to my colleagues about increasing mental health and addiction funding would be great, but that we would still be providing just a Band-Aid, just a little amount of what Denverites actually need. And so this past election cycle, I decided to go to the ballot. And I asked Denverites, are you willing to spend 25 cents on a $100 sales tax increase to provide about $40 million worth of mental health and addiction services to your friends, families, and neighbors right here in Denver? I was told that I was completely off base and that Denverites wouldn't want to fund this for those people. And I was like, those people? Do you mean ourselves, like us? I think you're wrong. I think you're wrong. And what we were really excited to find out is that 70% of Denverites voted in support of passing this mental health ballot measure. And so the best part of that is that we now have in Denver, the Caring for Denver Foundation, which is the largest mental health foundation in Colorado, and quite quickly will be the largest mental health foundation in the country. And it's all funded through taxpayer dollars. And so I use this photo to show collaboration, because what I found that was interesting in our quest to pass Caring for Denver was that people were actually willing to start to have the conversations around mental health and addiction needs right in our communities. The barriers have fallen down, the stigma has changed because of the work that people like you do every day to bring this issue into the light. So I picked this photo because now we're at an interesting phase of Caring for Denver. I knew Denverites were going to support the measure. I knew we needed the funding, and I had some ideas of where we needed to put it. But I didn't know what we were going to do next once it passed. And so we have started now a community engagement and stakeholder process to ask Denverites, what matters to you when it comes to mental health and addiction? Where should we put this $40 million a year? By the way, forever, it doesn't just end. Where do you want the money to go? How can we create a different infrastructure of support and wellness and integration right here in our own cities? So we are starting the community engagement process, and I gotta tell you, I'm very excited that people from across Denver of various backgrounds are coming to the table. And there's a reason for that. 1 in 4 folks in this room, right? 1 in 4 folks that we interact with, 1 in 4 folks, meaning someone up on this stage, is dealing with a mental health or substance use challenge or has, right? So we're not talking about other people, we're talking about ourselves. So we were able to bring together Democrats, Republicans, independents, clinicians, right? Schools, teachers, young people, to say, how should we put this money? Where should we fund? And that's the process we're in right now. So I use this image, and then the song I think will come after I click a button.
Yeah, there you go.
Because we are all family, right? You guys know the song. Anyone want to get up and sing? No? No takers here.
They're waiting for you.
Because our hopes are high, right? Our future is bright. We are having the conversations, and our goal, it is in sight. We can change the way that we fund mental health and addiction services. We can get people the access to the treatment that they need. It will be funded, and Denver has a really bright future because of it. So thank you to all the Denverites who are here who support this measure. I look forward to the conversation. Thank you.
So Leslie, quick question before we move on to John here. So what you were able to accomplish in Denver with this was unprecedented, right? Is there any other city that has gone to the voters and asked them to, spend their own tax money on mental health like you were able to get done?
Yeah, so it's interesting because I'd like to say it's completely unprecedented, but in this day and age, nothing is, right? I mean, there has been other communities that have come together and said we need to focus on this issue, right? So as I traveled the country and even to other places in the world, looking at how mental health and addiction is funded, the infrastructure that's built, there's other ways of doing this, right? There's other communities that have come together, maybe passed the measure through their council, but not at the level that we have right here in Denver. But on the same ballot this past cycle, we had 10 communities across the state also vote for mental health and addiction services in some way. They didn't create a separate foundation. I kind of know what politicians do because I am one, and I know that sometimes we pass things and then we decide about 5 years later that we want to use it for something else, right? Or we want to pull the money down and take it out a little differently or use it a lot for admin, and I said we shouldn't do it that way. We need to put it in a separate foundation so that we know the funding will go to these priorities forever. And if you want to change it, you got to go back to the ballot and ask for people's support. So that's the unique thing about Caring for Denver. But Denver is not the only community that can pass a measure like this. When you have 70% of voters supporting something, it can happen across the country. So we're looking at running similar measures in other counties across Colorado, and I've even been talking to other states and other cities about how they can make this a reality in their homes as well. What I learned that was really unique is that Coloradans, Denverites, community people, they want to know simply that the funding is going to come to their community, right? That it's not going to go into some ridiculous infrastructure, that it's not going to go into some black hole of government, but that they're going to see real change in their communities. That's our commitment from Caring for Denver, and that's how we're going to move it forward. And I suggest that if you're looking at these measures in your communities, that you keep it as local as possible so that we can really touch, feel, and change people's lives.
And I can tell you from the journalism perspective covering this story, one thing that was really powerful is hearing the stories of people who were going to be helped by this money, and they were out there working on the campaign, trying to convince other Denverites to vote for it, and I think that may have been one of the reasons why the result was as it was, 70%.
Yeah,
so,
thank you.
Yeah, very, very powerful campaign. Now, we just heard the perspective from Colorado. Now we're going to hear some perspective from Ohio. John?
Good evening, and thanks for having me. My name is John McCarthy. I'm a founding partner at Speire Healthcare Strategies. We're a boutique healthcare consulting firm that works with both private and public entities across the nation. So my background, just real quick, so you know where I'm coming from, is I started out in the budget office in the state of Arizona. I did that for a couple years, and then from there I joined a healthcare consulting firm called EP&P Consulting and worked with a number of states on reforming their Medicaid programs. So I got to work in states like Oklahoma, I did work in Ohio, New Jersey, Maine, Georgia. Best was Hawaii. I got to work in Hawaii for a little while, Arizona, and some of those places, and helping them reform their Medicaid programs to figure out how to serve people in a different way. What I then found was I did that for 10 years, and I was telling people what to do, but every time I tell them what to do, they wouldn't do it exactly like I told them to do it, and stuff would go wrong, and I was like, I want to see if I can do this. I want to see if I can actually do this. At the time, I was living in the District of Columbia, and so I was lucky enough to become the policy director for the DC's Medicaid program. So I was policy director there for 3 years, and then I was lucky enough to become Medicaid director for the DC Medicaid program. So yes, DC has a Medicaid program. DC is treated just like a state when it comes to their Medicaid program. So I was in DC for 5 years. I worked for Mayor Fenty. He lost the election. I then was out of a job, and I needed another job, and I got a couple offers, but I was lucky enough to be offered the job to become Medicaid director in the state of Ohio. I got to move to Ohio, work for Governor Kasich. I was Medicaid director for 6 years before I left. We made a bunch of changes in Ohio when I got there. One was we expanded Medicaid. I know when you talked about presidential debates, that was one of the issues that often came up. First question to Governor Kasich was about Medicaid expansion, and how could a Republican possibly do that? We did a lot around that and made a lot of changes. So anyway, so I left and then became, and started our firm. So with that, I got, here is my picture first. And it's a couple of things, and I'll then play the song. But you see, on one hand, we're at a crossroads, right? We're at a point where things are diverting, and I'll come back to that. But on the other hand, we're at the exact same time, we're in roads coming together. So as a Medicaid director, right, that song and those lyrics is what I saw. Every day there's a mountain at my gate, right? And no matter what I give, it would take and take and take. So the old joke about Medicaid was it's like Pac-Man and it eats up the state's budget, right? In nearly every state, it's close to 50% of the budget. And so you've got this issue. So no matter what you do, you feel like you can't control those things. And so what states are doing, there's a whole bunch of different things that states are doing. And as I was talking about before in those pictures, you see a little bit of a divergence. There's two different places that states are going right now. One is you see states doing things and implementing different policies like community engagement. Also, some people call them work requirements and what it takes to be enrolled into Medicaid. There's other states that aren't doing that and saying, no, we're not going to do that. We're going to let people in as much as possible to get coverage. So you see this divergence of how states are running their Medicaid programs. There's also obviously a divergence on expansion. Some states have done it and there's still states that haven't. And what happens in that place? On the other hand, if you're in Medicaid circles, and I'm saying even in Medicare circles also, and at some level of commercial, the thing that everyone's talking about is social determinants of health. That is the topic that comes up again and again and again. And in every state, you're seeing states trying to figure out how do you use social determinants of health to reduce healthcare costs, and what are those things that you can do to pull that together and make that happen. And we'll probably talk about a little more in a minute.
Thank you. Ever hear me? So it's like a TED Talk. I want to just walk around and do that. My name is Marvin Figueroa. I'm the Deputy Secretary of Health and Human Resources for the Commonwealth of Virginia. Before I took on this role, I was the Senior Advisor for Senator Mark Warner of Virginia, dealing with all the work that he did on the Senate Finance Committee. But more importantly, or equally important, is that I am a Honduran immigrant that moved from a small village in Honduras to this small village in New York called the Bronx. And I mention that because I think the way that I view healthcare is shaped by my personal experience, my personal and professional experiences, and we'll get to talk more about that later on. I think in Virginia we acknowledge and recognize the ongoing fragmentation of behavioral and medical health. For a long time, you got one service here, you got one service there, and we have been trying to implement a number of different initiatives to try to merge that gap. Because it doesn't only happen in terms of where you get the services, but it's also operational, it's about training, it's about financial, and also about how individuals are reimbursed. But nonetheless, this is the situation that we're seeing in Virginia right now. We have 9 psychiatric facilities, about 1,500 beds, and at any given time, most of our facilities actually are running at 95 to 100%. And so while we are interested in investing more in community-based services, the fact is that we have to continue to invest in our state psychiatric facilities because of this ongoing crisis in our hospitals. And so not only is it the front door where we have an issue, and so that's a breakdown of all the services that we have in the community. Something happened where that individual didn't get what they needed. But also once they are in our facilities, some folks about 200 people at any given day are ready for discharge, have been cleared for discharge, but because of the lack of supports to go back, they have to stay in our hospitals longer than expected. And so if you look at the graph, that green line and that red line are both national. And so in 1993, the country had that breaking point where it was 50-50, and then you see a continuing investment in the green, and so community mental health services. Virginia is where the country was in 1993. And in large part, it has to do with that we have to continue to invest in our hospitals because we have that immediate need in the status quo. And different from my federal experience, you have to balance a budget when you're in the state. You just can't write a bill and figure out how to fund it later, as much as we want to do that. And one thing that my song is about, that one of these days we have to integrate behavioral health and with medical health, and medical health is going to be the one that approaches behavioral health. And this is the song.
It's me. I was wondering if after all these years you'd like to me to go over everything. They say the time's supposed to heal you, but I ain't done much healing.
So with that, I'll pass it on to you.
All right. Got a little Adele in there, huh?
Whenever I could add Adele, I add Adele.
So with your song, what do you hope people get from that? What's the main message?
I think the two industries or the two professions have developed in a parallel track. And for different reasons, whether it's reimbursement or just the nature of the different professions. We see pockets of promise where there are better outcomes. We all know that an individual that has asthma has asthma plus depression is going to cost more to the system. And so, but that information is not widespread just yet, I believe, right? Unless more of the spaces where I occupy. And so the song is that merger. We have to have that conversation. Who approaches who is kind of the question. I said medical was going to approach behavioral, but I'm not sure that's the way it's going to work out. But nonetheless, as my colleagues just mentioned, we're at that crossroad where we have to acknowledge that we need to integrate more. What will be the incentive to do so, right? Cost, it seems it's something that people are consistently talking about. But even the cost avoidance could be part of that. It's not necessarily about reducing costs, but also avoiding some of the costs associated with not paying attention to both.
All right. Should we sit down? All right. We're not going to stand throughout the whole thing. I make everyone a little uncomfortable. So one thing I thought it might be a good place to start, since Ben referenced it before, is the opioid crisis. We know that life expectancy has been dropping the last 3 years. We know that the opioid epidemic is a key part of that. There may be some money coming to states through the settlement. If you've been following the news, there's a possible settlement from all these lawsuits. But in the short run, what do you think we can do to address the opioid crisis? I'd like to hear from all three of you.
Yeah. Well, you know, the opioid crisis is one that I always I found very interesting in how we're approaching it now. As a state legislator, I came in really looking at focusing on criminal justice in our communities, right, the criminal justice system. And we know that the war on drugs has disproportionately impacted people of color and low-income folks. So prior to coming to my work as a legislator, I was actually our previous governor, Governor Ritter's senior policy advisor for human services, where I served on the meth task force. I served with Attorney General.
You said meth.
Meth, yeah. Methamphetamines.
Yeah,
Mm-hmm.
big problem here in Colorado.
Yeah. And that was, I'm not going to date myself too much, but let's just say over 10 years ago. And what I realized then was that we were addressing the meth issue in a I thought, not the right way. For one, we looked at it because we were concerned about middle-aged, white, suburban moms who were getting addicted to meth simply because they wanted to clean their homes better. That was the rhetoric that we were using. And that if we told folks to try it not even once, just to have a nice public, campaign of not even once, that we were going to break this addiction to methamphetamines that we were seeing on our streets. But we were so specific on what drug we were tackling that we didn't realize the kind of cyclical nature of the different drugs that come in and out of our communities, and ensuring that any intervention that we put in place would not just affect the meth epidemic, but would actually affect other substance use disorders as well, right? Substance use issues as well. And so when I came into office, I remembered kind of how we dealt with the meth issue. And I looked at the fact that we weren't really helping anyone. We didn't change the trajectory. Meth is still a leading issue in Colorado. It's actually not opioids, it's meth, right?
Yeah.
And it's still killing folks and just devastating our communities. But the interventions that we put in place didn't impact people of color in positive ways, didn't impact lower income folks. In fact, we just pushed people across the board into our Department of Corrections. Currently, our Department of Corrections is our largest mental health or addiction facility in the state. And locally, it's our jails. So while we had an opportunity, I think, in a time period where people were quite sympathetic to a meth user at the time, right? We didn't actually create interventions that were going to change the trajectory or really address addiction or mental health issues in our communities. And so now that we have this opioid epidemic, I'm very keenly aware that we are talking about it in a different way because of what the person looks like, right? That's affected, and they're white, which actually isn't the case but that is who the sympathetic person is. And so what I started to do was saying, okay, if we have a time where folks are actually thinking about mental health and addiction in a different way, our communities are starting to say that we don't need to just criminalize and that we can't actually criminalize our way out of addiction, right? How about we put in interventions in place that will actually have long-term effects in our communities? How about we actually get funding in, even if it's specifically for opioids at the federal level or the state level or local level, but create actually more opportunities for community members to get help when they need it, before crisis, during crisis, and after, right? And so when it comes to this conversation about opioids, I think it's great. I'm glad that we're having this conversation right now. I think it's an opportunity for us to put in good, common sense public health policies into the books that are not just fear-based, but I will say that we only have a small window to make that happen. That's why it was so urgent that we ran Caring for Denver when we did. Because the pendulum will shift back, and folks will go back into wanting to just incarcerate ourselves out of this, or villainizing the people who are addicted. And I think that's what we need to look at.
So when you say a real narrow window, you're talking about people moving on and going back to the old way of doing things. That's what you worry about?
Yeah, going back to saying, okay, we gotta, we're annoyed with this now. We're no longer as sympathetic. We need to move folks into the criminal justice system because I don't want to deal with this anymore. Or we're no longer going to fund that, $200 million program that we had around addressing the opioid epidemic because it's either solved, which, okay, who determines that, right? Or our communities don't believe that these interventions would work, or we don't want to fund them anymore. So I think we have to be keenly aware that funding priorities shift, both in the government sector and in the philanthropic sector. And we have to utilize this opportunity that we have now to create infrastructure in our communities that can withstand some of those kind of funding ebbs and flows that we'll find. I also think that we cannot address the opioid epidemic specifically without putting in place harm reduction activities in our states. We have to have things like, I believe, supervised use sites in our communities that need them. We need to make sure that people can be under the care of a medical professional who need help and support, and that we don't just think that recovery is the end of the line, right? Or that if you go to treatment once, that you're good to go, but that it's a journey and it's a continual struggle, and that we need to ensure that people have opportunities to fail, to succeed, and to thrive.
So John, from your perspective, states may be getting a big, bucket of money potentially, and maybe even, sometime we'll hear about it anyway, sometime soon. What do you think that money should go to? Do you agree with Leslie that, with Representative Herod, that we should see this money being, spent on, treatment, prevention, some of these kind of things?
Yeah, I do agree from that standpoint of that if you look across the nation, and so I was in Ohio in the middle of ground zero of the opioid epidemic. I took over in January of 2011. You got Dreamland was written about it, Hillbilly Elegy, and it talks about all the different issues there. Yes, the money coming in is going to be helpful. States have done a number of different things. We were lucky enough. One of the reasons we expanded Medicaid was specifically to address mental health issues, which Governor Kasich was big on, but also on the substance abuse issues of how do we get to individuals. The issue that we have, and you all know this very well, is you have a lot of money come in. Now, where does the money go? When we say it goes to treatment, that's great. And as my issue as Medicaid director, and just a lot of states are thinking about this, is who is doing good treatment, and what does that mean? How do you count that? What does it look like? If you look at the data that we would see, the success rates of programs, what we would hear is that after a year, only about 10% of the people that were going through the programs in Ohio were still off of drugs. And so the question is that good? Is that bad? Can you expect something more? So the question is, who are those providers? At the same time that we're funneling money into new providers and trying to bring new providers up, you just saw, I don't know if you all saw it, but there's an article in the paper the other day of a provider getting busted in the state of Ohio. This is the second one now in 3 months, who made millions of dollars off of the opioid epidemic in treating people. And so if you didn't read the last story, the person actually bought the car for the DeLorean from the Back to the Future and then the Ghostbuster vehicle. So there's a lot of money. This is the problem with the money when you have these big influxes of money. How do you then figure that out? From a policy perspective, how do you set this up? And as providers, you all know this. In the Medicaid world, generally everyone is paid the same, whether you're a good performing provider or a poor performing provider. How do we start making those changes and moving to a better value-based purchasing systems where you're actually paying providers who you're getting good outcomes for, and what are those policies that you can put into place to make those happen? At the same time you're doing that, you're dealing with all of the morality issues that are popping up. We still had a sheriff in the state in Ohio, one of the counties, who forbid his officers from carrying Narcan. Just forbid it. And then we've got in other places.
Forbid them from carrying Narcan, naloxone, the opioid reversal drug?
Yes.
Wow. Why?
Yes. Because he believed there was a moral issue. And that what you see, and we hear this time and time again, it's the same people showing up in the emergency room. They get their, they're saved from a couple, now we have fentanyl though, so sometimes it's 8 or 9 shots. And then they're back in the next day, overdosing the next day. And there's a whole bunch of different reasons for that. So going back to social determinants of health, we also can't just treat a person and say, as you were saying, hey, this is an issue about addiction and just deal with that. There's a whole bunch of other supports a person needs at the same time, and how do you make that happen for a person?
Marvin, let's hear the perspective from Virginia. Are you already having discussions about what might happen with money should the settlement come through?
Yeah, we're having the initial conversations. We have an ongoing program based on some of the STR grants and SOR grants that went to the states to be able to respond to the epidemic. I will say 3 things and then kind of build off of those things. One is a cross-secretariat initiative. Oftentimes, especially with this issue, we make it seem as it's only health's responsibility to respond. And the reality is our secretary that works on public safety, who is involved in this initiative, is our secretary that is responsible for labor / jobs, is commerce, right? Because again, it is much more than just the substance that the individual is addicted to. It's a whole different host of different societal issues that have contributed to where that person sees themselves now. 2 is we're working more on trauma-informed care. The governor went to one of our local jails not too long ago, and he talked with some inmates who were in treatment, and he asked them, when did you know that you had a problem, and when was the first time that you had an opioid? And it's either they were prescribed because they played sports and they had an injury, or they started to use because of the family situation. And so that tells you again that it's much more than how that person presents, but there's also these hosts of other issues that person brings to bear. 3 is looking at our payment structures. We talk a lot again about whole person care, but we have a payment for addiction, right? That's called ARTS. That it has a whole host of psychosocial supports about funding MAT, medically assisted treatment. But the things that we pay for in the mental health, the things that we pay for that person if they are have an addiction are not the same thing that we pay for if that person has a behavioral health issue. And so you can get partial hospitalization, for example, if you have an addiction. But if your primary diagnosis is behavioral, you don't get partial hospitalization. And so again, we kind of separate those 2 things, which in reality, if it's about whole person, that payment structure should reflect the fact that we care about the whole person. And so this next budget, we're going to introduce legislation to be able to kind of bring in line some of those services, or align those services.
What do you think is the single most effective thing that could be done with that money in Virginia? What would be at the top of the list?
That's a tough question. I think prevention is hard. Even when I was in Capitol Hill, there would be good ideas that people bring to us about prevention. The thing is that we couldn't score it, right? So we couldn't say, because I did this action, this didn't happen, and you don't get credit for what doesn't happen. So it was difficult to kind of push forward prevention. And I think I see similar traces of that perspective on the state level. And nonetheless, we are invested in prevention. We're doing a lot of work around treatment. We just expanded Medicaid, so about 325,000 Virginians now have access to health care because of expansion. And so now we're looking at subpopulations. So if you are an individual that has been incarcerated because of your substance use disorder, we're going to try to, before you leave state jurisdiction, state oversight, we're going to try to enroll you in Medicaid so you can have treatment when you leave. If you're a pregnant woman who is also addicted, we're gonna get you enrolled as well. We also have to ask the question, if a woman with children seeks care because of a substance use disorder, more likely than not, the state is gonna take custody of her children. So does that encourage treatment and recovery, or does it not? And we have to grapple with those really difficult questions, because what happens if the individual keeps the children and something bad happens? And so these are just tough issues that we are not gonna find the right answer to. What is a practical response? And it's not gonna be the same thing across the board, and policies are about the same thing across the board, right? It's really hard to be nuanced with a bill. So we're working through those things.
And John, on this one, you're gonna be seeing some interesting fights around this, because with the tobacco settlements, it was pretty clear that the states were getting the money that was gonna be handed out. With the opioid lawsuits, a number of local jurisdictions have brought these forward, and so...
Right, so cities and counties, and we've seen that in Colorado, for
yeah,
sure.
so there's a fight in some states, Ohio's being one of them, where the state's saying, no, the money should be... The Attorney General actually got in and said, no, all the money should come to the state, and the counties and some of the cities are saying, no, it should be coming to us. You know, my former boss and with the president of West Virginia University, they're saying it should all go to hospitals. So it's going to be interesting where it goes. And back to your question on where should this money go, Marvin brought up a lot of good areas. The other area is the courts. You know, how do you have drug courts? And so you do more diversion so people aren't going. That takes money to run a drug court, so should some of this money be going to some of those local courts? And again, it's very state specific of how things are funded. If you live in a local control state, you know, and the money is actually coming from the local level, you may have an argument that it should be going down to the local level. If it's a state run, if it's a state controlled at the state level, then, you know, maybe the money should go there. But it's going to be an interesting, I think, debate of where some of this money goes.
Do you have an opinion about where that should go? State, counties, cities, hospitals? Divide it all up?
At this point, I don't have an opinion. I think there's a lot of good programs, and, you know, it's up to every state to decide of how it should be done.
Representative Harris?
I think while I'm in the state legislature, the state, no, I do think it should be a mix. I think the state should be able to have some of the funding, and then the county should also have the funding as well. And I think that that's something that we should work on together. I think that we need to spend some of the money to break down the ridiculous silos that we've built up over generations, honestly, around access to care and treatment. It's quite obvious. When I was in the governor's office, I chaired the behavioral health cabinet, which was all of the cabinet members that dealt with behavioral health. Quickly, we realized that I was running the entire cabinet, because there wasn't a cabinet position that did not have a touch on the behavioral health system. They just didn't talk to each other. So, right, you think it's definitely human services and healthcare policy and finance. Probably you thought of corrections, but did you think of local affairs? Did you think of ag and wildlife, right? Did you think of these other areas that are actually also providing mental health and addiction services through their agencies? So I thought that was really interesting. But at the end of the day, I think that we need more treatment. We don't have enough treatment in our communities, and prevention's important. I think prevention is very important, but we also need more treatment.
And with the foundation that you've set up and the money that's coming in, what proportion of that will go to treatment? Has that been figured out yet?
So we haven't figured out the formulas yet. That will come through our strategic planning process. And that will come from the communities to determine what our priority areas are. But the interesting thing is that we know that treatment is needed so heavily. So as a legislator who's worked on these issues, and I've tackled the mom issue as well, because my sister has been in and out of the criminal justice system for about 30 years, and it started with addiction, right, and crank out in Oakland, and has obviously continued on and manifested in different ways in the system. And so we said, if you're a mom seeking treatment up to a year postpartum, you can go and you don't have to worry about necessarily automatically getting flagged and having your children taken away from you. And in that bill, we also said that we'll provide early childhood education, mobile vans, mobile units, so that the families get support, but that mom can go, and that actually the whole family can go and access treatment. That's extremely important, because people just weren't coming to us, right? They weren't coming to us for treatment because of that fear. And so I think we have to just put some reality into this, right? So the other piece is, now that I've been working on this issue, people come to me and say, my son, my cousin, my uncle, my loved one is in crisis. I need help. What can you do to help me? And I tell them, right now, in Colorado, in Denver, give me about 6 weeks and I can get you into a program. 6 weeks. When you're in crisis, 6 weeks is not okay. And then I have to add,
Yeah, you
please
need like
don't-
6 hours.
Right,
maybe,
please don't die, right?
Yeah.
Or go put yourself on a 72-hour hold. That's probably one of the most terrifying things that you can do, right? Or go commit a crime and I can get you in drug court. That's absurd, right? We have to stop thinking about this issue as one that we have to funnel through the system and instead get people access to services and treatment right where they are. So with Caring for Denver, we did a very interesting thing. We led the campaign through the art movement, through artists, and we asked our local museums to come and help us out. The Museum of Contemporary Arts is where we launched Caring for Denver, and they're one of our partners moving forward because they want to provide at least an entry into mental health and addiction services through the museum. Think about that, right? A different access point for people to get care and treatment. That's what I hope we can do with some of this money that's coming into the system. Think about it all completely differently.
And for those of you in Colorado, or those of you not from Colorado, one of the really fascinating things they did with their campaign was they had folks tape their own little, 2-minute, roughly, testimonial telling a story about their life and how maybe they fell into addiction and how this program could help. And that was a very effective way of getting the message out. And you could see that online. It was in ads as well. And anyway, very, very effective. I think at some point we're going to be able to have folks from the audience ask some questions. So if any of you are interested, you can maybe start heading for the mics and we can start getting some questions asked from the audience if you'd like. We've got probably about 20 minutes left.
Can I add one thing?
In the session. Yeah, go ahead, Marvin.
I think all of these are policy decisions, right? So when it comes to the provider base, reimbursement really matters.
Yeah.
And where does the state go when they have a budget crunch? They look at provider reimbursement. And so you lower the reimbursement, the base decreases, you have to wait 6 months or longer for treatment. What do you do about barrier crimes, right? So crimes that you committed while you were under the influence of that substance. Again, these are not easy questions to answer, right? What crimes that were committed are crimes that could be screenable over time so that you could be allowed to provide certain services, and what crimes we are not able to say you could come back to society fully. Those are those are really tough questions to answer. Comprehensive harm reduction is another big one. In places, in our southwest regions of Virginia, where it tends to be much more conservative, we also tend to have, the epidemic has hit even harder. How do you talk to the sheriff about comprehensive harm reduction? And then what laws do you review within in Virginia to be able for them to feel comfortable? Because their job is law enforcement, is not necessarily treatment and recovery. Mm-hmm. And so you're fundamentally asking these individuals to think about their jobs differently. And some of these folks have been in that position for years, decades almost. And then and some of them also have to get reelected, right? So these are the dynamics that you have to manage. And these are all policies and these are all decisions, all driven not only by the folks who are locally elected, but also the folks who elect them. And so these are kind of the things that on a consistent basis we have to struggle with, especially when it comes to substance use.
But it's no longer this partisan issue, though, right? I mean, we've got the Koch brothers running Right on Crime, partnering with Democrats who've not always been, and I'm a Democrat, if you didn't know, couldn't figure that out, I'm a Democrat, that haven't always been great on these issues either, right? The war on drugs arguably was led by Democrats, right? Mm-hmm. So in certain areas. And so I would say that, it's not the same as it used to be. We can actually elect Democrats and Republicans, sheriffs, and all kinds of elected officials who actually get that we need to address this issue differently and that what we're doing isn't working. So you talk about the policy piece and the barrier crimes. I agree with you that we need to really look at those, and you're speaking my language as a member of the Judiciary Committee. One thing that we did here in Colorado I think was pretty obvious and straightforward. We defelonized simple possession. Across the state of Colorado, we defelonize simple possession. If you are simply addicted, there's no other crime that you've committed, but having a substance on you that you should not have on you, you don't need that felony following you around for the rest of your life. And when you are ready for care and treatment and you go through and you're in recovery, to have that felony on you for simple possession means that you are gonna have a hard time getting a job, you're gonna have a hard time getting housing, and when you're on the streets, right, you make decisions to stay warm. One of those decisions might be to use again. But if you have the opportunity to give back to your community, to take care of your family, to work and get a home, you're more likely to stay on that path to recovery, right? So we defelonized simple possession in Colorado, and I did it with a Republican co-sponsor from a conservative area of Colorado. We can do this across the state and across the country, and I think it will make a huge difference. That's where we start. And then we look at some of those other crimes that are happening, things like prostitution, right, in our communities, low-level theft. And we think about, is felony the right thing to put on that, right, for your first offense? Is that felony label the accurate thing that we should be doing? Or should we be advocating for things like drug courts, like diversion, right? Like getting you into treatment, like misdemeanors, so that you, yes, in Colorado, by the way, if you have drugs on you, you could still go to jail. There's still jail time, but it's not that felony offense. So what else can we do to ensure that people have access to treatment and can get on the right path once they're ready to?
I think we might have a question over here. Yeah, go ahead, tell us who you are and give us your question.
Is this on? Yeah. Will Lucenhop, University of New Hampshire. One, I just wanted to thank you so much for kind of, in a way, talking about how much policy is racialized in our country. I'm going to throw in incomized here for a second, but I'm going back to the question at the beginning about how many of us are involved in policy. And the one thing I just want to say is, if every day you're not thinking about how even the benevolent policies you're enacting, whether they're very small or larger, are not impacting people differentially by race or gender, sexual orientation, or and then income, we will all be repeating those things because implicit bias is powerful. And if we all took the implicit bias test, most of us would probably show up pretty strong. So I'm just so glad that you're talking about that's so front and center in the discussion. And again, encourage everybody to be, that's stuff we have to think about every day, or we will enact those things unwittingly. Thanks.
Thank you.
Thanks. Right. Thank you. I think we've got someone over here too. Go ahead.
Hello, my name is Alexa Charlie Hansen, also from the University of New Hampshire.
All right, New Hampshire, very well represented.
So inspired by all of you, and thank you for coming and talking. I think one of the things that I'm always trying to think about as both a provider and a clinical faculty member is how can I break down some of those silos and artificial barriers that are created just because they're the status quo, they're the way that we've always done things in the systems that we work, whether you're on the mental behavioral health side or whether you're on the medical side. And just one of my takeaways from this whole thing that I'm just gonna really take away, and I hope that everyone does, is this concept of what can I do within my own organization to reach out to break down those barriers, because it's going to come from us. I do this activity with my graduate students where I actually have them map out the continuum of care for mental and behavioral health services in their communities, because I want to know what in your community, they come from all different places, right? What are the acute options? What are the partial hospitalization options? What are the community health options? And when I look at what they come back with their community surveys, they're all over the map. There are whole communities in this country that have 2 community-based organizations, or there are whole communities in this country that have all community, no acute. And until we address that, I really think, yes, it has to come from policy, but it also can come from some of our own organizations thinking about how we can do things differently. Thank you.
All right, thank you. That might be a good jumping off point to talk a little bit about integration. Healthcare, as you all know, can be incredibly fragmented and siloed. Give us one idea about how to better integrate mental health? Maybe you want to start with that, John?
Sure. So, coming from the largest payer in the state of Ohio, and in just about every state, the largest insurance company is the Medicaid program, our lever is one, which is payment policy. And how do you change your payment policy to have integration actually happen, not actually create barriers in there and have providers billing in different ways? And how do you decide to make that something that works? And so we experimented in Ohio. So we tried to do patient-centered medical homes. We had our first shot at it, and it totally failed. But there's things that I did, and as a Medicaid director, I always said, we're going to do a whole bunch of stuff, and some of them are going to fail. Hopefully 95% doesn't fail, but some is going to fail. We tried patient-centered medical homes the first time, and it just didn't work. And the issue we ran into was who should be the patient-centered medical home? Because my firm belief was that for most of our people who had behavioral health issues, they were more comfortable seeing their behavioral health provider than they were seeing their physician. So we tried doing it where the patient-centered medical home was the behavioral health provider. What we ran into was they couldn't get providers, physical health providers, to partner with them or come into their offices to provide those physical health services. Whole bunch of different reasons for that, some of it being reimbursement issues, other issues around electronic medical records. So we had to back off of that, and then Ohio's been working on that ever since. Reintroduced patient-centered medical homes on the physician side, and it's actually worked a little bit better than it did in the before. And so there's still bumps in the road and things like that, but it's I'm not certain that's the best way to go. But it's how do you come up with these different ways to say, here is a reimbursement for services, you figure out the best way to do it to make those happen, and hopefully there's some upside and downside risk on it. And I know you're all going to say, oh yeah, but in my state I'm not paid enough to begin with, so there's no way I can take downside risk. I agree with what you're saying. I think some of those is how do we break down those issues and going forward around that.
So in Colorado, I'm aware of some different facilities that have put these different services under one roof all together. That seems to be a growing trend. Is that working? Is that a good route? Are there big obstacles to doing that?
No, I've seen that work also, and actually, when we were working on infant mortality in the state of Ohio, which the disparity between African American and Caucasian infant mortality is huge, so we were doing special grants to help do it. Some of the best providers we saw had the services all under one roof, because for many of the mothers who were addicted, whether it to be whatever drug it was, what we found was the stigma wasn't there if they were just going to see their doctor, and then when they went to see their doctor, they happened to see a psychologist or social worker or somebody else, and just all happened in the same place. They had really good outcomes, and so we're really pushing in that direction. Just the question that it came down to was, in that scenario, who's in charge? Not at the state level, but in that office, who's making the calls and who's making those decisions, and that's where you actually saw some friction across providers. But that model worked much better than some of the other models where even if it was across the street, the stigma of going, here is your physician's office, but then you have to go across the street, and everyone knows that's the behavioral health provider, that still created some barriers.
So Marvin, how about an idea about integration in Virginia?
So I think first and foremost, leadership matters in this situation. So we even structured to be siloed, right, in terms of how our agencies, right? So we have an agency that deals with behavioral health, and then we have Medicaid. And depending on who the director and the commissioner is at any given time, there may or may not be conversation. And so part of the strategy is, like, how does the Secretariat encourage, I don't know if it's a bi-weekly meeting or is joining or set up a structure by which they have to accomplish something together so that those two folks are able to talk. We're undergoing a process right now to look at some value-based payments, as was mentioned earlier, and that they look at readmissions related to behavioral health and then structure the payment so that behavioral health and medical health have to talk in order to get an incentive payment, or in the future would be a penalty regarding that readmission. But again, value-based payments sound simple, and you're paying for value, but structuring them and figuring out how to, the internal infrastructure to collect the data, getting buy-in from the providers, and also having a sufficient payment that it encourages a different behavior is more challenging. And so we're we're undergoing that process now, but that's the direction that we're headed.
I think we have another question over here. Yeah, go ahead. We're getting down to the lightning round here, less than 10 minutes. So.
Okay,
Yeah,
my
go
name's Jeff Randall. I'm from Madison, Wisconsin. I work as a behavioral health clinician, but I also work as a social worker in the emergency department. And, we're dealing with a lot of boutique psychiatric care and the revolving door with seeing patients. And oftentimes in that role, I end up working a lot with the police. And, they've said that social workers are, or that the police are social workers without guns, or with guns, and that social workers are police without guns, which is a strange concept. But needless to say, I wonder, I think it's important to think about like expanding tents, and I was wondering if any of you could talk about police engagement so far as CFHA or so far as being in the system, because oftentimes I'm a social worker, boots on the ground, that's what I want to do, and oftentimes our partners are the police, and there's certainly assertive community treatment, and there are some pretty interesting initiatives, and I wonder if you could talk about that as far as integrating, collaborating with police, which is a hot button issue, but if you could speak to that.
I see you nodding your head,
Yeah.
Representative.
No, it's not that. I don't think it's that hot button of an issue. I mean, I think that when law enforcement doesn't believe that they are mental health or addiction, behavioral health providers, they're wrong, and they're probably in the wrong industry at this point, and the wrong career path, because it really is. All of our first responders know that this is one of the top issues they deal with on a day-to-day basis, even our 911 dispatch, right? And so we have to look at ways to have, providers and mental health professionals, clinicians, riding along with law enforcement so that when they come to a scene that the appropriate interaction happens, right? And so one thing that Caring for Denver has done is required that we will expand and fully fund a co-responder model right here in Denver, which already exists, but it doesn't exist on every shift, and it doesn't exist in every single community in Denver.
Tell us what a co-responder
So a
model is.
co-responder means a law enforcement officer actually rides along with a mental health professional for the entire shifts. And so when they interact with someone, and I've seen it happen at the Capitol, I work at the state Capitol, of course, and it is just a kind of a hotbed for folks to come and talk about their concerns. It's the people's house, we say, so anyone can come in, but there's often times where there is struggles and people who definitely need access to resources that are not getting them. And so I've seen Denver Police Department show up with a co-responder and how they're able to de-escalate a situation, how they're able to get someone access to services they need, how they're able to take more time with that specific person so that the interaction goes in the right direction. So what we said was we have to expand out that model. But the thing that I love about the co-responder model, which I think it's very important that we continue it, where law enforcement is riding along with a mental health professional, is because we know the stigma exists. My mom was in the military, and I think, she chose to go off base for mental health support because she knew it would be on her record. Same thing happens with law enforcement. People will know, right? We're changing that, but it's still a part of the culture and in the fabric. But guess what? In Denver, law enforcement officers are signing up to have a co-responder so that they can talk through their issues too. When you got a therapist in the car with you for 8 hours, you're talking about what's going on in your home life, your wife, your family, your situation, and guess what? That officer is then less likely to have excessive use of force incidents happen. The communities are actually much safer, and we find that actually even the taxpayers are spending less dollars when people are getting sued because their law enforcement interaction with the community is not where it should be. So we need to continue those models. We need to make sure that everyone gets access to mental health and addiction services. If you're low income, if you're middle income, if you're high income, you should have access to services, and it's really hard in our communities to do so. The other thing that I'm looking at doing and that we're looking at doing with Caring for Denver is a model, adding on another model. And that is a model that we found is working out of Eugene, Oregon. Has anyone heard of this model, Cahoots? Look it up. Cahoots is a model where actually 911 can dispatch an EMT and a mental health provider instead of law enforcement. And so they're actually tied into the 911 system. So someone can call and say, I think cahoots needs to come on scene. This person may have a cultural issue and doesn't want to interact with law enforcement, or law enforcement doesn't need to use their time doing this welfare check. We think it's actually more appropriate for cahoots to come in. I did a ride along with cahoots earlier this year, and I saw firsthand how it works. We stayed on scene for 3 hours with someone who definitely needed the help and support. Law enforcement showed up. Cahoots was able to step up. Law enforcement stepped back, made sure the scene was secure. They left the scene within about 15, 20 minutes, were able to move on. They didn't have to arrest the person, which it would have ended in arrest. The person didn't have to go onto a 72-hour hold, but instead, we actually were able to get them into a van and get them into treatment, get them to take their meds and go see a provider. That's what they needed, and talk through their issues, right? 3 hours we stayed on scene. That could not happen with a law enforcement, with a police officer. It couldn't have happened. So we're looking at seeing how we can put a model like Cahoots in place right in our communities here in Denver, and how we can fund that.
Yeah, I was just going to ask the funding question. So something like that, would you envision the state paying for that, the city, your foundation?
So we're looking at it being funded initially through Caring for Denver. I think the interesting thing about Caring for Denver and foundation philanthropy money is that you can use it very differently, right? So we can then use it to pull down, the federal resources where available, the state resources where available, but at least we know that the payment will be covered. So things like the van, right, gas, the infrastructure, the build out of the 911 system. Those are things that we're able to do at the city level with Caring for Denver funding. But then at the state level, I realized that actually if we wanted to make that happen, we might have to change some state laws as well to release those barriers. And so I'm learning more about those, and you'll probably see legislation from me next year that really helps to ensure that these models can take hold in our communities and that we don't have unneeded barriers to ensure that this takes place.
So we were talking near horizon. Let's talk a little bit far horizon. Ben was discussing earlier that I think there's an election next year or something. I'm not exactly sure, but I heard a little something about that. So if you had an opportunity to speak to the presidential candidates, what would be your advice about mental health in America? What's the number one thing that you would like for them to understand and also perhaps advocate for? Do you want to start with that, Marvin?
Sure. I think first is mental health parity. So we have laws.
Mental health parity.
Yeah, mental health parity.
Yeah.
So we have laws in the book, but they're rarely enforced, or for a number of different reasons. But we had our Medicaid office into my office recently, and our Bureau of Insurance, which manages insurance within Virginia, and they hadn't met each other, although they both deal with networks in some form or another. And they're trying to figure out kind of a unified way to move forward to ensure that we are having some parity between behavioral health and the payments for behavioral health and for physical health. I will say too that I think that's kind of the biggest one right now for kind of the work that I do.
And we're talking parity. You're talking about getting paid at the same level as other providers, right?
Mm-hmm. It improves the provider base, right? I think whenever you're not, I think I'm focused a lot on the finances right now because we're going through our budget process in Virginia. So all I can think about is the numbers. But I do want to go really quickly to a previous question about law enforcement. And if you look at the slide that I provided, the image slide, so we have a law in the books in Virginia called the law of last resort. It resulted because a senator, his son was supposed to be involuntarily committed. Because there was no bed, he ended up stabbing his father and ended up committing suicide. Mm-hmm. And so now, if you need a bed, we will find you a bed in Virginia, regardless of where you are. What that has done, as you saw from the image, is that now law enforcement is having to travel all across Virginia looking for that bed. And so you go from Marion, Virginia, which is southwest. You have to go to Hampton Roads, which is about 4 or 5 hours. Or you're in Northern Virginia, you have to go to Catawba, which is about 3 or 4 hours. And law enforcement is frustrated because because the way that they're reimbursed is by boots on the ground, not necessarily by traveling with the individual, which not only is it getting that person there, but also they're tired, right? Like they have to get hotel rooms, and all those expenses are incurred by them. And I use that example to say that the relationship between behavioral health and law enforcement is driven by state conditions and what laws are in the books. and then the local conditions themselves. Who is the sheriff really matters. And I'm starting to know that in a more visceral way. And so making sure that if you are going to engage law enforcement, you're engaging them in the language that they speak, because again, they view themselves as keeping law and order, not necessarily most of the time. I think it all depends on where you are. That's a very essentialist comment to make, but it depends on where you are, but by and large, that's what we've seen in Virginia.
John, do you want to say anything about law enforcement, or talk about your advice for the candidates?
Probably should talk about law enforcement, but I'll talk about the candidates for a second. I think in the U.S. what we've seen is at a federal level, right, there's only limited things that they can do, right? They cannot mandate payment parity in Medicaid programs. They don't have the authority to do that. I don't think they'll ever be given that type of authority. But on the other hand, they're driving policy from a bigger picture. But one of the things that we see is incremental change is what tends to work the best in the United States. And so you have big changes. You have a lot of pushback and different issues that come in there. So some of the advice, even when I was working on the last presidential campaign, is what is it we can do to see our problems, and how do we make those fixes to them? What are those pieces that we can attack and make changes to? There's a lot of discussion now about Medicare for all and moving to things in that. You saw in the debate that was one of the issues that came up, where even in the Democratic Party there's debate of is that the way to go or not, and does it solve things? The other issue, I want to jump back to parity for a second. What I've seen is it's not a matter of lack of enforcement. The law, actually, the parity law is, if you really get into it and read it, it really is only saying that there's parity when it comes to prior authorizations for services and barriers like that compared to primary care. And so there is, if you look, when we did this on the Medicaid side, we looked at it in private and commercial insurance, everyone met the parity law, but guess what? It still didn't mean that there was parity like we, as in this room, would define parity. So there's probably some more that can be done in that area to move things forward around that.
Yeah, I think I'll stick with the parity train, and I think about it a little differently too. I think that we also have to, we tend to have these conversations around the uninsured, the underinsured, and low income, but what about the rest of us too, right? And so when I think about parity, and my friends in the insurance lobby will probably call me tonight, but I think that we need to ensure that if you are covered, if you're covered and you have health insurance, that mental health is required too. Right? Just like if you break your leg and you get care and that's covered, your mental health treatment should be provided as well at the same level. And I'm sorry, 5 or 6 treatment, 5 or 6 hour sessions is not enough. I don't know how many of you guys have gone through therapy, hopefully most folks, but I don't know how many of you all have worked through any of your issues in 5 or 6 sessions. Anyone? Because I want to talk to you, because you're magic. So we need to make sure that people can actually get access to the mental health and addiction services that they need, including therapy, right? That should be there. The other thing that I would advise my friends who are running for office at every level is talk to the young people. We have an alarming suicide rate here in Colorado. I think now I just saw we're #1 for youth suicide. We have to start talking to our young people and figuring out how we're going to break this down, how we're going to change that. And we can't think that it's just, we're going to figure out ourselves as adults and it's going to work, right? So empower our young people to have conversations with each other, support things like peer support for young folks and those in recovery, and young folks in recovery, because that exists too. And let them talk to each other about how to get support. Let them be the entry point. Because that's, I think, what's going to lead us in the right direction. So talk to our young people. I think it's really important for us today.
Yeah, that's a great point. We're at Colorado Public Radio. We're working on some stories about just that topic, just what you were talking about. Many of you, I'm sure, are working with young people. You're seeing it yourselves. It's just a huge challenge. They've got incredible stresses in every state, and certainly in Colorado, for sure. We're coming right back to the end of our time here, I think. Do you think we have time for one more question, Ben? Or?
Sure.
Okay, yeah. Go ahead.
Thank you, Ben, and thank you all. My name is Barry Jacobs. I'm a psychologist from Philadelphia, and I work for Health Management Associates, a national healthcare consulting firm. A lot of the conversation tonight has been kind of centered around one question, which is how forceful should the role of policymakers be, whether it be about integrated care, parity or OUD care. Point in case. We know from the research that the best treatment for OUD is medication-assisted treatment. I think most policymakers would accept that on the basis of the best empirical evidence we have. Among the provider community, only about 50% of substance abuse and behavioral health providers believe in MAT. So there's a gap between where the provider community is and where the clinical community is. Sometimes the policymakers are actually out in front of the clinicians in making change. So how forceful should state legislatures or Medicaid agency directors be in essentially forcing us to pursue more evidence-based practices, particularly with something like OUD where lives are at stake? And I'll just leave it at that.
Representative Herod, you want to take that?
I think we should be direct with the money that we're providing. I mean, if we're providing the funding at the state level, we should be directive, but we should also listen to the clinicians and the folks on the ground who are doing the work. You know, I always say if you haven't stepped into a correctional facility, you shouldn't be writing policy for DOC, right? If you are going to write policy around these issues, you need to have conversations with clinicians. And if you don't have a clinician that's elected, that's representing and serving in your body, then you should work to make sure that they're elected too, right? And so I believe that if we know there are best practices that work, we should make sure that we fund them. But we also need to have room for innovation, and we need to make sure that we're actually talking to the folks who are delivering the services. But when we find something that works, I do believe in being quite direct. I do believe in being quite bold. I mean, I've passed 52 pieces of legislation in 3 years, and that's kind of how I approach things. But I don't think it should be uninformed, right? And I don't think it should be so stringent that it can't evolve or move, or we can't learn from our mistakes and say that didn't work, and course correct quickly and move forward.
All right. Well, I think I'm getting the cue to move forward onto the next thing. I think you've got another session outside, right? What's that? Last slides? Want to do that? Okay. All right. I think we've got one last set of slides.
All right, we'll run through these quickly then.
Yep, go for it.
Because I think you initially said 35 minutes each. No, just kidding. So where we're going, and this is a photo I like to use of our city, and you see that this Platt Park, and this is probably what people think of Denver. We're all, you know, out in the rivers and floating around and healthy and all fun and all great. But really what I use this for is because there's so many ways to enter into this river. Do you see that? There's many entry points. That's what I want to see for mental health and behavioral health, mental health and addiction services. I want us to be able to, we talked about this a little bit, but I want us to be able to go to the library, right? And understand that there's treatment options there, that there is no wrong door policies. At our museums, in our schools, at our courthouses, sure, but not just in the criminal justice system, not just in our ERs, but so many places in our communities. That's where I see us going, and I think with funding like Caring for Denver, like settlement dollars, like federal and state dollars, we can actually make that happen. But we gotta think about these entry points a little bit differently, and that's what I'd like to see us going when it comes to behavioral health treatment here in Colorado and throughout the country. And so then my song is that I can see clearly now the rain is gone, right? Because the obstacles have been lifted. And there are places that we can go, and I don't have to tell people wait 6 weeks, right? That the obstacles are gone, and there's a clear path for you to get access to treatment where you are, when you need it in our communities. So, thanks.
So my picture is one of social determinants of health. I think that this is the area that we're going, and what we're talking about is 20 years from now. Where do we think the healthcare is going? I think we have finally crossed that threshold. As Medicaid directors, we've been working on this for 30 years, so it's hilarious to me. I was also Vice President, National Association of Medicaid Directors. We've been talking about this forever. Finally, people are talking about it. I think it's finally going to be an issue where people say, we can't just address healthcare. We've got to address the whole person and everything that comes along with that person, including things like education. I was Medicaid Director in the District of Columbia. I mean, one of the issues we had was very unhealthy kids, and one of the reasons was they wouldn't go outside. They that wouldn't go outside of their houses because of crime and other issues. And so we addressed that issue. We made crime-free zones. And guess what we saw? Better health outcomes for those kids in D.C. when we did those things. So the song that I have on this one is probably one you've heard before. So I think it's going to be the end of the world as we know when it comes to healthcare. And I think the reason for that is a couple. One is costs are just going out the roof, right? And I'm not talking about insurance costs. I'm talking about actual costs of services. And this is not just in Medicaid, but on the commercial side, there's been many of articles for employers and how much it's costing there. Again, not insurance, but costs for services. That's going to have to address at some point in time. I think transparency is going to help in that. I know there's an issue. People say they don't shop. I get it. People won't shop. And there's issues on how do we measure quality. But you know what will happen is when those amounts are in the paper, the press will look at it, and you'll have some people questioning those things. And I think you'll see a slowing down of the growth in some of those different areas. Lastly, AI, artificial intelligence. I think artificial intelligence is going to really change healthcare as we go forward. I know many of you probably have gone through the healthcare system. I've recently had it happen, and I've seen a couple of times, I was talking about John with this earlier, there's a person that I know who was diagnosed with breast cancer. She's 82 years old, and we went to the surgeon, and the surgeon says, guess what, we got to do surgery, right? Because this person's a surgeon. And when we said, are there other options, the surgeon said, no, well, actually took it to the committee, and the committee said you should do radiation and then surgery. So we're really, we're just doing surgery. We go to the primary care doc, and the primary care doc says, well, wait a second, she's 82 years old, she's got breast cancer, did they test for it? Yes, it's a kind that could respond to that new pill that's out. So guess what? She started taking the pill, and the tumor shrunk after 3 months by 20%. So there's been no surgery, the cost is much less, and so how does something like artificial intelligence fit into that to help doctors make decisions on things going forward?
So I know I started my slides with kind of a grim picture of what's happening in Virginia right now. But I also think that there's opportunity in chaos. And what the situation that we have right now has inspired is tough conversations about what services we have in the community and what services we should have in the community, which are two really different things. And so right now we're building a foundation that provides that is able to provide access to behavioral health services, regardless of what place in Virginia you are. But more than that is, how do you leverage Medicaid dollars to ensure that you're not just building systems, but you're also building sustainable systems that can last for a long time? And then how do you engage providers so that there is some accountability and some shared values as to where we want to go? It's going to be a tough process. We are heading into our biannual budgeting process. And again, we are going to have some tough conversations that unfortunately Virginia has not had in the past. And I am encouraged that this governor has the courage to be able to lead those talks, but pray for Virginia, right? Because there's also a lot of vested interest in the status quo. And so trying to shake that tree is going to be more difficult than we think. But I do believe that in 20 years, we're going to be in a better place, and we're able to play this song.
Started from the bottom, now we're here. Started from the bottom, now my whole team here. Started from the bottom, now we're here. Started from the bottom, now the whole.
And I put Michelle and Barack just because I just love them. Yeah. So I hope you appreciate it.
Me too.
All right, let's give our panelists a big round of applause. Marvin Figueroa, John McCarthy, Representative Leslie Herod.
Thanks.
Thank you.
Thank you. And thanks to all of you for all your good work.
And welcome to Colorado, you guys. Enjoy your time while you're here, and please don't forget to spend money. It goes to a good place. Thank you.